Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We'll be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they'll be addressed.
Good morning, everyone. I'd like to introduce our mentor for today, Dr. Paul King. Dr. King is a board-certified orthopedic surgeon who specializes in the treatment of disorders of the hip and knee, including joint replacement and reconstruction and arthroscopic knee surgery. He has performed several thousand joint replacements at the Anne Arundel Medical Center. Along with being board-certified by the American Board of Orthopedic Surgery, Dr. King is also a member of the American Association of Hip and Knee Surgeons. He has served as a director of the Center of Joint Replacement at Anne Arundel Medical Center, and he's also been selected as a top doctor in orthopedic surgery biannual survey of physicians in every edition since 2007. He's also been named in the Capital Newspaper Reader's Choice Award for orthopedic surgery every year since 2011. Alongside his mentorship, he's also published and presented his research on orthopedic topics and has been a speaker at local and national conferences. And I would like to pass it off, and I would like to now request Dr. King to start today's session. Thank you.
Well, good morning, everybody, and thank you for having me. I appreciate being here. We'll have I prepared some comments and a talk, and then I know we have some time for questions at the end. And I hope write down your questions or save your questions. And I hope you find this interesting and informative. I'm going to share my screen here. Attempt to share my screen. Good. And is that working okay, Manaho? You going to see that, right?
Yes, we can see that.
Okay, great. So again, thank you for having me today. I'm happy to speak to people thinking about going to medical school or who are planning on going to medical school. A great profession. As Manaho said, I'm Paul King, and I'm an orthopedic surgeon at Anne Arundel Medical Center here in Annapolis, Maryland. I don't know if most of the people on the call are local. It's a beautiful day here. I'm sitting outside. I hope you have wonderful weather where you guys are. I'm also the medical director of our Center for Joint Replacement here in Annapolis, and we've recently become a system. So we now have a hospital outside of Washington, D.C., Doctors Community Hospital, that I'm also responsible for the joint replacement program at that hospital as well. Okay, so here, Luminous Health, that's the name of our new system. This hospital in the picture here is where I've worked for 20 years now. We have a very big orthopedic department. We're the busiest orthopedic hospital in the state of Maryland. So I'm an orthopedic surgeon, and I focus, orthopedic surgeons can do hand surgery and spine surgery and nerve repair and sports surgery and shoulder surgery. And my practice has evolved to focus on disorders of the hip and knee. And so a little bit about me is that I spend a lot of time in surgery. That's not every orthopedic surgeon doesn't necessarily do that. Let me just close this window here. There we go. And so I do about 2 days a week in the office and 2 to 3 days a week of surgery. I do research. I love doing research. Our research is not, when you think of research, you think about basic science or lab research, but my research focuses on clinical research, and I'll talk a little bit about that more later. 2014 or 2012 to 2014, I was a team of one, and now I'm very fortunate. We have this amazing team of people who support our research, and so after I'm done this talk, I'm going to read through a couple of papers that we're working on. So on nights and weekends, I enjoy, just reading some of the research work that we're working on and helping guide the team. And again, it's predominantly clinical research based on how can we improve outcomes for, the patients we're caring for, retrospective studies, prospective studies. My practice, even more specifically focusing on the hip and knee, focus predominantly on hip and knee replacement, revision of failed replacements, treatment of fractures of the hip and femur, and sometimes those involve, metastatic disease in the hip and femur. My nighttime job, or my extra job as the director of the Joint Center. And the picture in the top here is our team of surgeons, and we do somewhere, over 2,000 joint replacements a year here in Annapolis. So we have a very big program, having done 10,000 joint replacements over the past 5 years. So lots of clinical material and a lot of patients we care for, and a lot of operational and infrastructural type things that I work on continuously to make that safe and reproducible, and try and provide very high quality patient-centered care with our really amazing teams we have here. We have wonderful nurses and therapists and doctors and physicians assistants who help us do that. Research, I joked on nights and weekends. This is one, we published a lot of papers. This is one of the papers we published recently. So the fact that we do so much surgery gives us what I think almost is an ethical obligation to really study like how those people are doing, and how can we help them do better. What can we do to make the care more equitable, or improve outcomes and reduce complications? And so this is a study we published, and we're doing a follow-up study on disparities in joint replacement. And Manal Hill actually had an excellent, amazing concept for a study that we're just finishing now, about people who live in underserved areas in Maryland. Are their outcomes inferior, or well, not inferior, or different? And how could we potentially make those outcomes better? And so those are the type of work we do, using our clinical experience to look to see how can we improve care for the next group of patients. So I'm thinking that everyone here is thinking about going to medical school, or is in medical school, or wants to go to medical school. So just a little bit about that journey, basically. I went to the University of Maryland School of Medicine in Baltimore, right up the road from here. Everybody, I think, would know that that's a 4-year program. The medical school, it's challenging, certainly, and you guys know that it's challenging to get in, and it's challenging to do it. But I loved medical school. It's just amazing, the breadth of things you can learn about, and the fascinating things you can learn about in medical school. And so from there, I decided to do orthopedic surgery. And so orthopedic surgery involves a 5 or 6 year residency program. The first year is an internship, which is a lot of general surgery, basic surgical training. And I did that at the University of Pennsylvania. And I did 5 years. There's an option for a 6-year track, and that track usually involves research year, which is more common now than it was 20 years ago when I did this. So 5 or 6 years. And then in orthopedic surgery, you could do your 5 years and go into practice and be a general orthopedic surgeon. But many people choose to do a fellowship. And so I went to Boston for a year to learn really advanced hip and knee replacement reconstructive techniques. And so I spent a year in Boston. That's called a fellowship. Some of the fellowships in different specialties are 1 year, and some are 3 years, depending on the specialty. In orthopedics, the fellowships are 1 year, allowing for very focused study with a very expert group of faculty in a specific area. There are fellowships in hand surgery and trauma surgery and shoulder surgery, sports surgery, foot surgery, tumor surgery, and hip and knee reconstructive surgery, also sometimes called adult reconstruction. And so that's the fellowship that I did. And that was great. And then after that, I came to Annapolis, and I've been here ever since. So I am active in the University of Maryland Medical School alumni group, and they send little emails. And so you people on the call or watching this tape know this better than me, probably, these numbers. I mean, I joke, I think, and when I work with students in our research team, the hardest part about medical school is usually getting in. Once you get in, almost everybody graduates. I mean, it's obviously very competitive to get in. And these are the numbers for Maryland for this year, over 6,000 applicants for 140 spots. So I say, and it's the hardest part is getting in. And once you get in, almost everybody graduates, and of course, medical school is challenging, but I loved it. It's amazing the things you can learn and the variety of things you can be exposed to. Once you're done medical school, it's like the world is your oyster. There's a whole bunch of different specialties that you can go into. This is from the national residence match data. I think this might be 2016, for example, but there's all these different options, and they all have different levels of competitiveness, and you get to experience these in medical school on your clinical rotations. And I really enjoyed this time. It's usually you do it in the first and second year, but particularly in the third and fourth year of medical school, you get a chance to, do different rotations, and you can direct those electives and visit other hospitals and do away rotations to really explore, what you like the most, and then you apply for the residency. So really just amazing, breadth of opportunities and variety that you can choose, and really actually get to kind of test drive them with the rotations. And so each specialty has its little quirks, or each specialty has its strong points and its more difficult points, and length of training is different for each specialty. Some of the residencies are 3 years, and some are 5 years, and some of the fellowships are 1 year, and some of the fellowships are 3 years, depending on the degree of subspecialization. And this is a good listing of some possible options, but it's amazing the number of options. There are little like stereotypes. This is an ongoing joke between anesthesiologists, if anybody on the call wants to be an anesthesiologist and orthopedic surgeons. And so there's this ongoing, joke, and there's this stereotype that, orthopedic guys are all old men who used to play football in college and dumb jocks and that kind of stuff. That's definitely not true. That's the farthest from the truth. It may have been true decades ago. But there's all these little funny jokes, like the anesthesiologists say, oh, the orthopedic guys are just, working with power tools and saws and hammers, and, working to, fix the bone, and, not paying attention to the heart and the lungs. And then this is from England, which was a funny study, just meant to be facetious, obviously, that the orthopedic guys tested the IQ and the grip strength of orthopedic surgeons and anesthesiologists to show this is not real research, obviously funny research. But so each specialty has its little flavor, and orthopedics, again, typically the stereotype of dumb jock ex-football player, which is totally not true. Orthopedics is an amazing specialty. I'm super happy that I chose it. You really can make an amazing impact on people's lives, in terms of fixing deformity or helping people be more mobile. And that's, we'll talk a little bit about that in the next section. And this actually is great. Again, I love orthopedics. I mean, everybody has to decide what's best for them. This is from the Yale Divinity School newsletter, but this is just discussing a famous anthropologist, Margaret Mead, who talked about what she considered to be the first evidence of civilization. And she answered, they found a human femur bone, a thigh bone, with a healed fracture from a site 15,000 years ago. And she said that was the first evidence of civilization, because to survive a broken femur, the person had to be cared for. And so a broken femur or a broken hip would be essentially uniformly fatal without care. If you were 15,000 years ago, if you broke your femur, you would get eaten by a mountain lion, unless somebody was really looking after you. And so orthopedics, that's what we deal with. So, if you break your femur, your hip, your chance of survival is nil unless somebody takes care of you before, they would have, probably, wrapped the leg with a stick that would function as a splint. Later people were placed in traction while the fracture healed for a period of months. And now we put, titanium rods inside the bone or replace the hip. if you break your hip or your femur, and allow people to get up and walk right away. And so I thought that was a nice anecdote. So very important before we get into the next part. It's hard to do this sometimes when you're going through the journey, but you're faced with, you got to do well in college to get into medical school, and then you got to do well in medical school to get into the residency you want. And then you have to do, well in residency to get the fellowship you want, and then you want to have a good practice, and then you want to be successful. And excuse me, unfortunately, you can look at the whole journey as a bunch of hurdles, the hurdle to get into medical school. And then once you get into medical school, you can't relax because there's another hurdle to do well, and then another hurdle to get into the best residency program that you can. And so my advice, looking backwards, is you really need to enjoy the ride. Like, college is an amazing experience. Medical school can be an amazing experience. And so you don't want to look at each step as a hurdle to get to the next step, but actually live in the present moment and enjoy, the time where you are. Medical school is difficult, residency is difficult, but valuable, and you can't, if you get in that process of thinking like, oh, I have to, get amazing grades in college just so I can get to medical school. If you follow that kind of hurdle mentality, it can wear you down. So enjoy where you are, while still working hard to get to the next step. And when you get to the next step, celebrate that victory and enjoy being at that step, as you continue to work hard and focus on getting to the next level. Okay, so a little bit about, teleshadowing, I guess, which is the purpose of this talk, which I think is great, actually. Because of the COVID pandemic, obviously, has, greatly altered people's ability to, shadow, which is really an integral part of, deciding your interest in the field and helping determine, what you want to do with your life. So my life is, office days and surgery days. Office days are 2 days a week. Surgery days are 2 to 3 days a week. I do, my research and administrative work. And so it turns out to be a pretty busy life, as it is for many physicians in all sorts of specialties. My office days, I will typically see 20 or 25 patients. My practice has evolved so that when I see those patients, that's obviously not that many patients a week, but all of those patients, either at this point in my career, really either, are coming because they need surgery or they've already had surgery and we're making sure they're doing okay. And when I do surgery, I'll do 6 or 7 surgeries in a typical day. Somewhere around 60 surgeries a month. It's a lot, and I can only do that, therefore, with a very highly trained team. So I have 2 PAs who are with me, physician's assistants who are with me every day at all times, helping me see patients and helping me care for people, and they're extremely skilled. And then we have nurses, therapists, support staff, the whole team we work with in the hospital helps take care of the patients. And it's really that team approach that's really required in all specialties, to really deliver, high quality patient-centered care. So that's an important concept for you to remember as you move through your career. It's really, you really can't do everything by yourself, at scale. If you're going to try and really help the most people, you need good people around you to help you accomplish that in a safe and reproducible fashion. So a little bit about some of the things I treat. It's arthritic conditions, post-traumatic arthritis, inflammatory arthritis, like rheumatoid arthritis. They're greater, psoriatic arthritis, greater than 100 types. Avascular necrosis, which is death of bone, which occurs most commonly in the hip. We'll talk a little bit about that. Hip dysplasia, we'll talk a little bit about that, which is, congenital. People are born with hip problems. You see little babies who have to wear cast or brace. That's hip dysplasia. And as people get older, if that hip dysplasia is not treated, that can cause hip problems, serious hip problems later in life, even early in life. Knee injuries, we see athletes who have, torn their ACL. One of my patients this week had multiple surgeries from college lacrosse injuries and ended up with a horribly arthritic knee. We see a lot of fracture work, femur fractures. It's a long bone, as you know, your fingers are short bones. That's an oversimplification, obviously. Femur fractures, tibia fractures, hip fractures. And then the hip and femur are a common source of metastatic cancer. And if metastatic cancer weakens the bone, it can lead to a fracture. And that can be, of course, just like the example from the Yale Divinity school newsletter, a fracture in the femur or the hip can be devastating, particularly for somebody who has metastatic disease, and can be very poor prognostic factor. And so some of what I do is to, try and keep those people walking, basically. And so let's talk a little about osteoarthritis, by far the most common type of arthritis. It's the loss of hyaline cartilage. It can be in response to trauma, like if you break your bone and injure, the heel's in a crooked position, places abnormal stress on the knee, meniscus tear from sports, ACL tear, can cause knee instability, which can cause repetitive cartilage damage, which can lead to osteoarthritis. Can be repetitive trauma like wear and tear, like I've had, retired NFL football players or college lacrosse players who have had a number of injuries, or in Annapolis, we've had a number actually of ex-Navy SEALs who do the crazy things you see in the movies and, run 10 miles a day every day for many years. And, some of those type activities, and people who are genetically predisposed may lead to wear and tear arthritis. There's probably a genetic component that's poorly understood. Hip dysplasia or abnormal formation of the hip from birth can cause abnormal stresses in the hip, which can lead to hip arthritis. Meniscal tears, ACL tears in the knee, obviously, can cause trauma, which can lead to degeneration of the cartilage. This image, pathologic image or biopsy of cartilage on the left-hand side, shows normal hyaline cartilage with the swirling cellular structure. And then on the right-hand side, osteoarthritic hyaline cartilage, which has, just very few cells, which do not look healthy, and a very altered cellular matrix, which indicates substantial degeneration. Hyaline cartilage, which is the cartilage on the end of your bones that makes up the joints. There's different kinds of cartilage, fibrocartilage, hyaline cartilage. Hyaline cartilage is the joint cartilage. For those of you who eat chicken wings, when you look at the chicken wing, you see the shiny white, or if you have a turkey at Thanksgiving, you see the shiny white on the end of the bone. That's the hyaline cartilage, the normal hyaline cartilage. And then obviously the slide shows the abnormal hyaline cartilage, which is what happens when people get arthritis. And so osteoarthritis can involve really any joint, hands, anywhere in your body, your back, your neck, your feet, your ankles, your thumbs, your fingers. But the large weight-bearing joints like the knee and the hip are the most problematic in terms of disability, because they really affect your ability to walk or bear weight or work, do activities. Many people get arthritis, 27 million adults in 2005. It's one of the most common diagnoses. It has an enormous cost to the healthcare system, $128 billion in 2003. An enormous cost to the healthcare system, both in terms of treating it, but also in terms of lost hours at work and lost, productivity, and people being able to participate in the workforce. It's because of its effect on creating functional limitation, inability to work, inability to do activities. It has a very high association with major depression. And so people with arthritis are frequently depressed. And I guess the point of all this I'm telling you is that, again, there's that joke from the anesthesiologist about the orthopedic surgeon and their tools when they fix these things. But, these things like arthritis or broken bones have very substantial impacts on people's livelihood and their family and their life and their mental health. And so the scope of these problems is extremely impactful on many facets of a person's life, other than just, my knee hurts, I can't play tennis. Well, okay, you can't play tennis, but, imagine the person who's working to support their family and, they can't go to work, because of the arthritis. And so, these type of diagnosis can be particularly debilitating and very impactful in many aspects of a person's life. So when you have arthritis, osteoarthritis, particularly the most common type of arthritis, conservative treatments can be very helpful. So not everybody needs surgery, fortunately, and there's not enough time in the day for the orthopedic surgeons to do surgery on everybody who has osteoarthritis. But the first thing is really you need to establish a diagnosis. So this is when I talk about being in the office. X-rays, physical exam, MRI scan can be used to come to a diagnosis, so you make exactly sure what you're dealing with, that it's not something else. Rheumatoid arthritis and inflammatory arthritis can be treated with some very powerful medications that modulate the immune system. You guys all see commercials on TV about, psoriatic arthritis and rheumatoid arthritis and all these different medications, which are, basically immune system modulators, because those inflammatory arthritis involve your body's immune system attacking the hyaline cartilage or the synovium. And so it's important, if you have a problem with your knee or your hip or any joint, that if it's persistent, you really want to obtain a diagnosis, because osteoarthritis is treated much differently in the early stages than some of those other problems and issues. And treatment of the inflammatory arthritis at an early stage can actually prevent substantial degeneration that leads to the need for surgery later on. And so what's conservative options? Anti-inflammatory medications in the simplest form, that's Advil. There are, of course, a number of prescription options: physical therapy, muscle strengthening, range of motion fitness program, activity modification. The marathon runner who has knee arthritis, probably should pick a different sport, right? So if you have very bad knee arthritis, you might be better off becoming a cyclist or a swimmer for your exercise. So activity modification. Nutritional supplements may have some benefit, but a healthy diet is good for everything. It's good for your body weight. It's good for, your cholesterol, your overall health, your cardiovascular fitness. Some people who are later in life and, maybe just using a cane, which can unload 20% of the weight off an affected joint, may be enough to allow them to maintain relatively normal quality of life without having to do anything else. And then normalize BMI, body mass index. I think most of you probably know is, the ratio of height to weight. And there's obviously an epidemic of obesity in the world, and particularly in the United States. Only 16% of normal weight people have osteoarthritis, but 21% of overweight people and 30% of obese people have arthritis. The obesity, if you just think about the cumulative loading of the joint, if you're, the joint reactive forces from an engineering point of view, or a physics-free body diagram, for those of you who are taking physics, can exceed 3 to 5 times body weight. And so I tell patients, and this is, your physics teacher would tell me that this is an oversimplification, but losing 10 pounds if you have an arthritic knee can reduce the stress on that knee when you're walking by 30 to 50 pounds less stress. And so extremely substantial impact of body weight. And 66% of the patients who have arthritis are overweight or obese, and losing 11 pounds can reduce the risk of knee arthritis by 50%. So very substantial impact of body weight. And so a lot of my office time is spent actually not talking to people about surgery, but talking to people about modifiable risk factors, losing weight, fitness programs, physical therapy, how to strengthen your leg muscles, how healthy is your diet, are you avoiding, a high sugar, heavily caffeinated diet? And so these are very, very important concepts, for the initial treatment of arthritis. So I'm going to pivot just to the hip for a minute. So hip arthritis, loss of cartilage in the hip that results in, pain, limitation of motion. People have trouble walking, they have trouble exercising, they lose motion. So many people say, all of a sudden, over time, I realized that I had trouble getting into my car, or I could no longer tie my shoes, or I had to go get a pedicure because I couldn't clip my toenails. And that's because the arthritis in the hip, besides causing pain, causes limitation of motion. And as that progresses, it makes like walking difficult. People can't walk as far as they used to. They can't exercise. And then in some later stages, it even causes pain that wakes people from their sleep. The pain there is usually in the groin. So everybody thinks the hip, they'll come in and they'll point to their buttock or their back, which is typically not the hip. The hip pain is typically felt in the groin. And we talked about trouble tying shoes and socks. A lot of people have back problems, and it's confusing. Sometimes even very seasoned clinicians have trouble differentiating back pain from hip pain. And so we spend a lot of time trying to differentiate the two so we can arrive at an appropriate treatment option. But hip pain, typically in the groin, typically associated with reduced range of motion, like tying your shoes, clipping your toenails, putting your socks on, getting into the car, and then sometimes causes pain to the knee and can really affect your ability to walk. And so hip pathology, the most common is osteoarthritis, but there are the other causes we talked about. Metastatic disease is very commonly found in the hip among people who have metastatic cancer. Avascular necrosis is bone death. Obviously, it's pretty obvious if someone crashes their motorcycle and breaks their hip. That's, a pretty, obvious cause of a hip problem. And then, of course, as people get older and develop osteoporosis, there's a very high risk of hip fractures among elderly people who fall. And elderly people who fall and sustain a hip fracture, that can be a very, very dangerous situation with a very high morbidity and mortality 1 year after the injury. So the treatment of that to get them back on their feet as quick as possible is extremely important to their life, basically. And so regardless of inflammatory arthritis, osteoarthritis, avascular necrosis, the end pathway is the same, where you have destruction of the joint. And when that happens, we try conservative therapies, but at the end stage of hip arthritis, for people who are medically fit to have it done, hip replacement is really the way to solve the problem. And hip replacement, I don't just say this because I'm an orthopedic surgeon, is actually probably the most successful surgery procedure of any surgical procedure offered anywhere in the world. The long-term results are amazing. The short-term results are excellent. The complication rate is very low. It reliably relieves pain and restores function. So hip replacement has been considered one of the great surgical advances of any surgery anywhere, basically. When you look at all general surgery, all types of surgery, hip replacement has results that are really exceptional when you look at the outcomes, longevity, survivorship, and impact on people's lives. So this cartoon shows a normal hip on the left, and on the right-hand side is just an artist's schematic of an affected hip, where you see inflammation indicated by the red, which could be inflammatory arthritis, but particularly you see this normal white hyaline cartilage here on the left, and on the right-hand side, you see destruction of that hyaline cartilage. This X-ray shows hip arthritis. So on the right side of your screen, which corresponds to the patient's left hip, there's space between the ball and the socket here. And then on this hip, which is affected, you see complete loss of space, bone-on-bone arthritis. And so not to get too complicated, but these clips, I think you guys can see my point. Can you see my pointer, Manayo? Can you see the cursor?
Yes, we can see it.
Okay, so these clips here are clips from prostate surgery. Prostatectomy for prostate cancer is the most common reason for these clips in the pelvis. And so people who have prostate cancer frequently get adjuvant radiation therapy. And so if you could imagine this bone here, which is part of the pelvic bone, the ischium, looks slightly different than this bone here. And so I have seen a group of patients who have developed very severe hip arthritis as a sequelae of radiation for prostate bed cancer after prostatectomy. where the radiation that has to be beamed through the hip is focused on the prostate, but some of that radiation actually affects the hip and sometimes causes this kind of cartilage degeneration. And so there's not a lot written about this. We're actually have a research study on TAP to look just at this. It's a little difficult to study because the numbers of people who have this combination are relatively low. But in any case, regardless of whether this was radiation or this was a college lacrosse player who injured his hip 30 years ago and now has hip arthritis, this hip has bone-on-bone arthritis. Now this is a woman now. This hip on your left, the patient's right hip, has some space. It's not normal, but there is space there. But this hip, you can see the bone is directly on the bone here. So bone-on-bone arthritis. So all of the hip replacement approaches are based on, the anatomy of the hip, which is obviously the hip. The X-ray makes it look like, well, there's the bone, but it's obviously a very complex level of muscles, nerves, tendons, etc., surrounding the hip. So the hip is underneath all this. So to fix the hip requires an intimate knowledge of all this anatomy, which of course is slightly beyond this talk, but it's fascinating medical school topic, cadaver dissection, amazing, interesting anatomy to understand, how all these muscles interact so that a person can walk down the street or walk up the stairs. Hip replacement, now again, all the muscles removed. This is a artificial, a 3D printed bone model. And this is what a hip replacement looks like. So the ball, the arthritic ball would have been here. It's now replaced by this prosthetic component. And so the hip replacement is made up of a shell, which goes into the pelvis. The bone grows into the shell. It has a polyethylene liner, which is the cartilage replacement. It has a head, which replaces the femoral head, and a stem, which goes down into the femur. And this surface here is titanium porous surface the bone grows into. So these components your bone grows into, sort of like, I don't know if anybody's seen like a dental implant where the bone grows in. So this actually osseointegrates and it becomes part of the patient's body. And then now this artificial ball rubs on this artificial cartilage replacement and totally eliminates the pain. This is an X-ray of me. This is a fluoroscopic X-ray, which is a real-time X-ray that I take during surgery while I'm doing a hip replacement. And we just drew some lines on there to outline the bone. And this is bone-on-bone hip arthritis here. And then this, many ways to do a hip replacement. The way I do it is a muscle sparing technique. And this is anterior superior iliac spine is the little knob you feel on the front of your pelvis. So this is the iliac bone, which is your pelvic bone. That's kind of like where your pants hang or your belt sits. And the anterior superior iliac spine is the prominence on the front of your hip. You can feel it on yourself. And then this is when you feel your hip from the outside, that's the greater trochanter. So that's the greater trochanter there. The incision between here to work between the muscles to access the hip joint to replace the hip. And this patient is obviously not a patient. This is a model who's at some meeting trying to sell orthopedic surgeons this fancy table. But this is like the table we use, which is a very sophisticated table, which allows for positioning of the leg to safely access the hip joint between the muscles with the least amount of need for cutting muscles or trauma to the patient's, hip anatomy. And so I believe in the next slides that I'm going to have some surgical footage. So I'm assuming everybody is thinking at least about going to medical school, won't mind some surgical footage. So if you don't like surgical footage, look away. It's nothing too horrible. But this is now me, real patient. This is me. I was teaching other surgeons how to do this approach. And so this is that incision I talked about. This is flipped around now. The X is on the pelvic bone, the incision through the skin here, the fat. And then this is the tensor fascia lata muscle, which is the muscle that runs from the pelvis connecting to the iliotibial band, which is the band of fascia that runs down the side of your leg to your knee. And so this tensor fascia lata muscle here represents one of the intervals we use between the muscles to access the hip joint. And so this is my clamp. I've isolated the tensor fascial lata muscle. This is, I have a web page. It's paulkingmd.com, I think is the address, where there's a video of this surgery, which I show to patients who want to see it, who are having surgery. And I originally made to teach other surgeons how to do this approach, which I've been doing for 11 years, direct anterior approach to the hip. It was relatively new in the United States back then. Now this, they're more graphic now. You see the incision in the background. This is the femoral head that's been removed. This femoral head has bone spurs here and no cartilage left. You see this big defect here where there's no cartilage. And so this is me removing the arthritic femoral head through this little teeny incision. And then under X-ray guidance, you can see here on this X-ray screen that the head would have been here where I took it out. And this is a reamer, which is like a grater that's used to remove the arthritic damage in the pelvis. This is the pelvic bone to prepare it for the placement of the component. And so we do this under X-ray guidance to make sure it's appropriately positioned. Now, this is that same patient incision, this retractor now holding the tensor fascial lata muscle out of the way. And this is that plastic liner that's been snapped into this titanium shell that you can barely see the corner of here, that is now recreating the patient's socket. Now, this is now the prepared femur. So here's the muscle of the vastus, a deeper muscle now. And then the femur bone, this is where the head was, has been removed, and the inside of the femur medullary canal has been prepared. And this is that stem that's being inserted into the bone right now. And so after the stem is inserted into the bone, here's a cartoon of that. So this is that tensor fascial lata muscle. This is the femur. The socket's here in the background. The hip is dislocated at this point in time, so we can put the stem in and the head on, working between all these complex muscles we talked about. This is the patient's pelvis up here. A picture of me doing this is here. And so this is the patient that I agreed to be the model so I could teach other surgeons how to do this. And this is a ceramic head, which is this cool pink color, which everybody in the OR loves the pink color of this ceramic head, which is just a more advanced material. This is the stem, which has now been inserted in the femur, again, working between the muscles. The socket's in the background here, you can't see it. And then these are X-rays. So on the left is the hip with the head, bone on bone. Now the head's been removed and the socket is in place. Now on this X-ray, the socket is in place. There are some screws holding the socket in, and the stem is down in the femur. And some more X-rays of the same thing. There's the head's been removed. There's the socket. And here on these bottom screens are the hip replacement, which has been inserted. And so the device is down in the femur. There's an artificial head, artificial socket. And then we reduce, we say, so it's dislocated. We reduce it back together. So the head is in the socket. And then this is that patient a couple of days later. And so you can walk on it immediately. This is our wonderful physical therapist, do physical therapy right away. And you advance that physical therapy such that most people can walk a mile within 6 weeks or sooner, if they're otherwise fit and healthy. But we really get people back to activity pretty quickly. So it's a very gratifying, exciting surgery, and elegant with excellent results, and patients really benefit, in terms of getting back to work, getting back to life, getting back to sport, or getting back just to being with their family and able to do things. So another common diagnosis is avascular necrosis. Hey, Manahil, I'm sorry, if you don't mind, I didn't have my watch on. I just want to do a time check. Are we okay on time?
Yes, we're good on time. You can take your time, please.
Okay, thank you. So avascular necrosis is another diagnosis that can lead to a hip problem. It's death of the femoral head. And it's most common in the United States associated with chronic steroid use, alcohol abuse, like alcoholism, daily drinking, or trauma. The people who follow sports on the call will know the name Bo Jackson, who was a professional football player. who had a very serious hip injury while playing professional football, and ended up with avascular necrosis in his hip and had to have a hip replacement. So trauma to the hip or breaking your hip can cause avascular necrosis. And as the bone dies, it collapses, and that progresses to arthritis. And so this is about 20,000 new cases per year. There are many, many, many more cases of osteoarthritis, but this is an interesting, just from an educational point of view, 10% of hip replacements in the United States are for avascular necrosis. It occurs in younger people, because it's not an age-driven process. It's driven by, again, alcoholism, extensive steroid use, or trauma. People who do people who have it because of steroid use or alcoholism will get it in both hips 50% of the time. On other joints can be affected, shoulders, knees, but the hips are typically the most commonly effective, and also are probably the most severe from a functional point of view in terms of impacting people's activity and causing pain. And then in trauma, like hip dislocation, so not a dislocation of a hip replacement, but you see like Ravens fans, anybody a Ravens fan, Todd Heap, dislocated his hip, tight end for the Ravens. So when people have high energy trauma, NFL player, crash your motorcycle kind of trauma, car accident traumas, if you dislocate your hip, that can lead to avascular necrosis because of the trauma to the hip that occurs at the time of dislocation. It's also true in elderly people who break their hip. And the reason for that is that this schematic of the femur bone or the hip, shows that the deep femoral artery leads to the circumflex arteries, which surround the hip joint. And the problem with the hip joint is that all the blood supply to the hip comes off of this deep femoral artery. There's a very small artery that comes out of the pelvis that really atrophies after you're grown up, only as really active blood flow as a child. And so all the blood flow goes from the circumflex arteries into the femoral head, and anything that disrupts this blood flow, there's just no collateral circulation. There's no other way for the blood to get into the femoral head. And so if you break the hip through here, all these blood vessels get torn, and then this piece up here ends up with no blood. Steroids and alcohol abuse can cause emboli to form in the hip vessels or blockages in the hip vessels, almost like a hip heart attack that can interrupt the blood flow through these very small vessels and then cause essentially a hip heart attack, for lack of a better term, causing death of the bone underneath the cartilage in the hip. And so this 54-year-old patient is a patient of mine. He had NHL non-Hodgkin's lymphoma. A very common part of a 4-part therapy for chemotherapy for non-Hodgkin's lymphoma is high-dose steroids, which are like prednisone or injections of steroids, methylprednisone. And this is known to cause death of the hip bone. And other reasons are like kidney transplants. People get high-dose steroids as immunosuppression to avoid kidney rejection. Some people take high-dose steroids for very severe asthma, for example. And this is not like people take like steroids, you squirt some steroids up your nose because you have seasonal allergies. This is not that. This is from very high dose repeated use of steroids. But the bone, this is an MRI now of the hip, and this is the ball, and this is the socket. But this line here represents that this piece of bone has had its blood supply interrupted and has died. And so this is another patient. Actually, I'm sorry, this is same patient, just a different view. Let me orient you here. Here's the other hip over here, which is fortunately normal in this patient. This is the urinary bladder, which is full of urine. These are some of the large intestines here, okay? This is the hip bone on the, your left, but the patient's right. And this line here indicates that all of this bone here has died. And so what that does is, here's a side view, bone death of this whole piece here, these lines in this femoral head. Normal pelvis, the pelvic bone didn't die, just this head, because the pelvic bone gets its blood supply from someplace else. This is that head after I removed it. Sorry for those who didn't want to see that, should have given you a warning. But this is normal bone. This is the femoral head. So this is the cartilage on top here. And then I've taken it out because I was doing a hip replacement. Then I cut it in half so we could see the inside of it. And this is, on the back table while I'm doing the hip replacement. But this white bone here is dead. It's like chalk almost if you touch it. And it causes the bone to collapse. So you get these voids in the bone. And those voids lead to collapse of the cartilage here. And that collapse of the cartilage leads to very bad arthritis in the hip. And so this is an x-ray of that person's hip replacement. So again, the socket held in with screws, the liner, which you can't see because it's radiolucent, is the cartilage replacement, the head, and then the stem gone down into the femur. And this is where the head used to be. Hip dysplasia is another common thing we see and treat. Congenital hip disease. It's a wide spectrum. Identification at birth may prevent or decrease the long-term sequelae. And every baby who's born has a hip exam. The pediatrician or the obstetrician does a hip exam where they work the hips to see if they're in the socket, do they pop out of the socket. And in 1 in 10,000 babies, the hip's dislocated at birth. And 10 in 10,000, the doctor can sublux the hips and then put them back in. There's a family history. It's usually female. It's usually the left hip, and that has to do with interuterine positioning. But if this is now a 20-year-old whose hip was dislocated at birth and unfortunately never reduced. This is a patient we saw just a few weeks ago. You see, here's the hip bone here. Here's the socket here. The hip is dislocated, front view, side view. And so this is what happens if the hip is dislocated at birth and it's not taken care of at birth. It can be dislocated, which obviously is, makes it hard to walk and get around and do activities. And this patient is a patient of mine in their 30s whose hip was dislocated at birth, who had treatment, including surgeries to realign the bone, to re-deepen the socket. But what they've ended up with at only, the mid 30s, unfortunately, is partially dislocated hips with extremely, extremely severe arthritis. So just bone on bone changes in both hips. And they're partially dislocated. They should be in the socket down here, but now they're way up here. The head is like over halfway out of the socket on both sides. And this guy had trouble, real super nice guy, trouble walking. I mean, he dealt with this for years. Amazing. He played sports in high school. I don't know how he did it. But he ultimately came to be very limited in his activity as this arthritis progressed and came to see me. That's a side view of that hip. And so we did this relatively complex hip replacement with a very special device because of the abnormal anatomy, because of the dysplasia, but same concept. Bone grows into this artificial head, artificial socket, screws holding the socket in. This hip is now fixed, and he's going to have this hip done in a couple of months. That's the side view. And so just briefly on hip replacements, like I said, it's one of the most successful surgeries of any surgery anywhere. And like one of the reasons for that, I can show you a bunch of studies, but that would be boring. But like the 25-year survivorship of hip replacements, and this is talking about like the original design of hip replacement, not the modern design, but the 25-year survivorship of hip replacements is like 83%. 25 years later, 83% of the hips were still working. And so these hips, obviously, this paper published in 2007, these hips were done 25 years before that. And so that's using some of the original technology. We've had amazing improvements in the technology since then. So just excellent long-term result. And so I worry about doing a hip replacement, obviously, on somebody in their 30s, but there's really no other option for that guy because the arthritis was so severe. And so, we hope that that will last him a long time before it has to be redone. But it will likely need to be redone in his lifetime. But if he gets 15 years or 20 years, that actually, is his, very important time of his life in raising his children to be able to function. And so I have a little talk on the knee. I'm sorry, Manayo, I'm going to ask again. I'm sure. I just want to make sure. What time is it?
It's 10:54, but you can take your time. You can take as long as you want.
Okay, well, I can do this quickly and then they save some time for questions. Normal knee cartoon. So white hyaline cartilage, my very bad example about the chicken wings for people. I don't eat chicken wings myself, but my brothers do, so I've seen it. But the hyaline cartilage on the end of the bone, the white, the artist's depiction. This is a normal X-ray showing space between the femur and the tibia. This is an artist's rendition of an arthritic knee, again, red, inflamed, holes in the hyaline cartilage. This is an X-ray of an arthritic knee showing just bone on bone there. So now this patient has some space here, but still not normal, but no space here, just bone on bone arthritis. And this is the fibula, tibia, femur. So the fibula, is on, you can feel that if you put your hand on your knee, that's the bone on the outside. You feel the little knob on your knee, that's the bone on the outside of your knee. We call that the lateral side of your knee. So this is bone on bone arthritis on the inside. This is the most common type of arthritis in the knee. And this is called varus arthritis. And this makes a person's leg bow because there's less cartilage here than there is here. And so my wife will tease me because I'll be at the supermarket with her and I'll see somebody walking down the supermarket aisle and I will know immediately that they have arthritis in their knee. I don't like give them my business card or anything, but you can tell because they're, one leg will be very bowed and the other one will be straight. The normal leg is 5 to 7 degrees valgus, which means 5 to 7 degrees to the outside. And the people who get this type of arthritis develop substantial bowing of the leg because of the lack of cartilage. So we always try the basics first. And, the weight, again, is very important. This is arthroscopic picture of an early arthritic knee where you can see this is the meniscus here, which has all this calcium in it. So it's not normal, but it's not torn at least. And this is the tibia cartilage, and this is the femur cartilage. And this kind of hole in the cartilage, this rough surface, is damage to the hyaline cartilage. It should be smooth. It's very rough. This is an MRI scan of the knee, so looking from the side. And so this is the patellar tendon, if you orient yourself. This is the meniscus in the front, this triangle. This is the meniscus in the back. This is the calf muscle here. And then this is the femur, and this is the tibia. And this black is the cartilage. And you can see here it stops, and there's a big hole in the cartilage. So this MRI is the patient whose arthroscopic picture I just showed you. I put the camera in the knee to try and clean this up. But again, from earlier in the talk, hyaline cartilage doesn't regenerate, it doesn't heal itself. And so we can clean it up, but we can't cure it. There's no way currently. There's a lot of research on stem cells going on about how to regrow hyaline cartilage, but there's no effective way to do that in patients yet. And so surgery for knees is arthroscopic. You put the camera in the knee. There's cartilage transplantation, which I first did in my fellowship in Boston 20 years ago, and it's still like not much better than it was then. The advances in stem cells are going to greatly change this, but it's still not ready for prime time in terms of clinical application. It'll be great when it is. And then there are old-fashioned osteotomy, which means breaking the bone to take a bowed leg and make it straight. And then there's partial and total knee replacements. This patient is an 82-year-old patient of mine, wonderful woman from the Eastern Shore of Maryland who has arthritis, and you see bone on bone here, but pretty normal space here. Wow, that's great. So her arthritis has only affected this one side of her knee. And so she was an excellent candidate to have a partial knee replacement. She had just this side of the knee I replaced because this side was pretty normal. And the benefit to this is this can be put in through a smaller incision, less invasive, quicker recovery. There's the side view. There's the front view. And so she, within 8 weeks, was like basically back to normal. She's an amazing woman. Not everybody can heal that quickly, but she was back shopping and walking and playing with her grandkids very, very quickly. This patient has very bad arthritis on this left knee on your right-hand side, bone on bone. This is a knee replacement done by my now retired partner 14 years ago, which is still doing great. But this knee, this guy's in his 80s, this knee really bad, bone on bone, great trouble walking a bowed leg, couldn't walk more than a couple blocks, couldn't climb stairs, couldn't go on vacation with his family. And he ended up with this modern version of a knee replacement, which I just did just a couple weeks ago. I just grabbed that picture. This is a PACU recovery room picture right after I did his knee replacement. And so you see the knee replacement involves resurfacing the femur, resurfacing the tibia, and putting a cartilage replacement pad in the middle. So now there's space between the bones. So the bone no longer rubs on the bone, and the pain goes away. The motion is better. The leg is straight. And with good physical therapy, people can return to walking again. And so I probably hit that pretty close to an hour. That's good. So now we have some time for questions. For those of you who are from other places, there's downtown Annapolis, great place to visit if you're ever in the area. Although not today, because today's the boat show, which means that the street is packed with people. And I do have, let's see, I can show, let me see if I can do this. I have some just on my desk. This is like the real prosthesis. So this is a ceramic head. This one's not pink, it's black. This is a hip replacement. The bone grows into this matte surface here, and then the head goes on here. And then this is the socket, which is this, that's where the polyethylene liner goes. The holes are to put screws through to affix it to the pelvis. This titanium porous surface on the back here allows the bone to grow into it. So the screws hold it while the bone grows in. Once the bone grows in, the screws are superfluous but don't need to be removed. And so that is what that socket looks like. And this comes in all sorts of different sizes, obviously, because everybody's bone is a different size. This femur, the bone grows into these ridges here. It has the same titanium porous surface. And this here, I don't have the liner here. I didn't have a liner on my desk this morning. You know, it goes like this, but the liner goes in there and then it runs very smoothly. And this like costs like as much as a car, basically. Maybe an economy car. When it's in the box, once it comes out of the box, it's only worth what it's worth for melting it down for the titanium. But these are like super expensive. But once they're not sterile and out of the box, they're on my desk basically, and they're worthless. But pretty cool. Like this piece here might be, you know, retail value. This one piece here might be like $6,000 right here. You know, just because of the technology that goes into manufacturing it. And then I did have on my desk one femoral component. And this is again the femur from a knee replacement. Front, that's like looking at it. And then the side view. So this caps the femur so that that bone on bone now is resurfaced and the pad goes in the middle. All right, so I think that's all I have. I hope that was helpful for everybody. And happy to answer, of course, any questions.
Thank you so much, Dr. King. If anyone has any questions, they can feel free to ask now, and we'll now begin our Q&A session. My name is Amna, and I am a high school senior on the pre-med path, currently applying to BSMD programs. And our first question is, what are your thoughts on machines and robots such as the Da Vinci surgical system when it comes to best patient care?
Yeah, that's a great question. The Da Vinci robot is amazing. And I think it's really revolutionized, like, for example, prostate surgery, bowel surgery, some different gynecologic surgeries. And it really allows for pretty amazing accuracy with the procedure through very small incisions. And so it's very important, however, that that device be used only in extremely trained hands. And so I think it's an amazing technology, but the key, like in all these things, is the training. And now in orthopedic surgery, much of what we do focuses on the alignment, you know, the perfect places of the placement of the components. And so I've worked with some brain lab type devices that put optical sensors on the bones to help you line it up perfectly. And we also have some robots, which are not the Da Vinci robot, that can be used to implant the hip and knee replacements. But those things are still in development, and so they're extremely expensive. So that is definitely the future, but the devil's in the details, right? So they're very expensive, and you don't want to add unnecessary cost or potentially have learning curve induced errors, people using technology that they're not familiar with until you're absolutely sure that it adds value to the patient. And so I think in orthopedics, we're still on the beginning of that journey to determine, do the devices add value? What is the appropriate way to teach people how to use them? But I do foresee in orthopedics, it's the future, just like Da Vinci was like the future of prostate surgery. And now prostate cancer prostatectomy is most frequently performed with the Da Vinci robot with very good reproducible results in people who are, well trained at the device. Very good question.
Thank you, Dr. King. And our next question is, how long can orthopedic surgeries last?
Yeah, that's a great question. Yeah, some of the surgeries can last a very, very long time, and some of them, like a carpal. I don't do carpal tunnel release surgery anymore. That's hand surgery. If you have carpal tunnel syndrome and your median nerve is pinched at your wrist, and you make a little incision to free up the nerve, so those surgeries could take, like when I was doing them in my training, might take 10 minutes, very, very, very quick. Now, if I do a surgery where someone has a metastatic tumor in their femur, or I'm redoing a hip replacement that's failed, or someone's broken their leg very badly, those surgeries can take easily 4, 5, 6 hours. And so the average hip and knee replacement takes our team a little bit less than 2 hours. But we've done a lot of them. So the time varies based on the experience of the team. Yeah, so wide variability from minutes to hours, with the typical hip and knee replacement taking slightly less than 2 hours.
Thank you for that answer. And our next question is, how is the approach to treatment of osteoarthritis of an orthopedic surgeon different from that of a rheumatologist?
Yeah, that's a great question. Yeah, rheumatologists it's an amazing specialty. It's a very satisfying specialty. There's actually a shortage, at least in this area, and I think in many places in the country, a shortage of rheumatologists. And so our rheumatologists here frequently do not routinely treat osteoarthritis because the osteoarthritic treatment is many times handled by the primary care doctor, for example, or in some cases the orthopedic team when it doesn't, the conservative treatment, basically. But the osteoarthritic treatment by a rheumatologist is very similar to that would be provided by the primary care doctor or the orthopedic team. The rheumatologist's real expertise is in the treatment of the inflammatory arthritis, which involves, basically these immune modulating drugs, TNF alpha, tumor necrosis factor alpha inhibitors, or other medications that modulate the immune system. And those medications are very similar to like chemotherapy for cancer. In fact, some of the agents used to treat lymphoma are the same agents that are used to treat inflammatory arthritis because they modulate the immune system. And so the two treatments are very, very different. Rheumatologists can treat either, but their real expertise lies in those very complex medications that are almost like chemotherapeutic agents that require very careful monitoring and use.
Thank you. And our next question is, can you use a CT scan to diagnose osteoarthritis besides X-rays and MRIs?
Yeah, that's a great question. And you can use a CT scan. Now, there's been much, now in my training, which again has been over 20 years ago now, we use CT scans all the time. But there's been much more realization currently about the potential, not fully well defined, the potential effects of ionizing radiation like CT scans and X-rays. And so a CT scan involves a magnitude of radiation exposure greater than an X-ray. And so an MRI scan uses a magnetic resonance imaging. So no radiation at all. So you can use a CT scan to diagnose arthritis. We do use a CT scan in cases where people have tumors or fractures because it shows excellent bony anatomy. But the use of a CT scan for the routine diagnosis of osteoarthritis in most cases will involve the patient to unnecessary radiation exposure, which we always try to avoid.
Thank you. And our next question will be asked by Rushali, one of our students.
Good morning, Dr. King. First of all,
Good
thank
morning.
you very much for
Sure.
this beautiful platform. Thank you for coming for all of us. I really appreciate it.
Oh, it's my
I know
pleasure.
it's a Saturday and you're there for us. Thank you. Thank you. My name is Vishali. I'm a foreign medical graduate. I'm applying for internal medicine. But like I said, in the wards, we get to see a lot of cases. I've worked in India as a house medical officer. Even here during my rotation in the United States, I noticed one of the common thing post total knee replacement, many patients complain about knee limping or this uncomfortable feeling because of course there's a piece of a foreign body inside you. It's not a part of your body, which increases a higher risk of infection. So how many patients you have come across have gone forward and in the time has said that the limp and the pain gets better with the time? Does
Yeah,
it get better with the time? First,
yeah, that's an excellent question. Yeah, the hip replacement. Let me start with that. The hip replacement can be performed through these minimally invasive muscle sparing techniques, and people heal very quickly. Now, the knee replacement, because the knee, it's not a simple hinge joint, but in simplest terms, you think of it like a hinge. The knee will form extensive scar tissue after any surgery. And so physical therapy becomes critical to the success of a knee replacement. So a knee replacement, we know from research that's been done all over the world, the full recovery from a knee replacement takes actually 12 to 18 months. And it's because of that scar tissue that forms and the need for physical therapy. And EMG studies actually show that full return of quadricep muscle function after knee replacement in terms of muscle recruitment when measured by an EMG can take 12 months. So many people who want a very speedy recovery, we frequently have to counsel them that they have to be patient because that recovery actually takes for a knee much longer than people want it to take. The success rates for the knee replacement, however, are very high. You just have to look longer out
to the
to
recovery.
see the full recovery, basically.
Okay, thank you. I have one more question. So,
Sure.
as you said that throughout you have seen, I guess, thousands and thousands of knee replacement, hip replacement. Hip is in fact the big. Now, let's talk about the people with the diabetes, like one of the biggest risk factor and these replacement, and the worst is the infection. Now, as the technology is advancing, a lot of people are bringing more and more infection, less and less infection causing products. The technology in case of transplant, the transplant material is improvising. So in last 5 to 10 years, has it happened to your clinical practice that you've noticed the infection rates in diabetic are reducing, or you've noticed that the infection rates post, especially knee transplant, are increasing? That is my last question.
Yeah, that's a great question too. Yeah, infection is the most devastating complication of a knee replacement or a hip replacement because it always requires more surgery to cure it. You can't just use antibiotics. The infection, we go to great lengths to try and reduce the risk of infection. And so what's actually happened in the past decade, for example, is the infection rates have decreased. And in a high volume center where the surgery is done efficiently and quickly, the infection rates are usually very low, 1 in 200 or less. But what really we've realized through these retrospective studies, and we've done that with our own patient population, is that diabetes, smoking, and obesity are very strong independent risk for infection. And so we actually have changed our practice patterns, and this is true throughout the United States and probably many other countries as well, that if someone has a diabetic a hemoglobin A1C of greater than or equal to 8, we will not do their surgery until that's corrected. And so poorly controlled diabetes, we will not operate on those patients until they're optimized by their primary care doctor. Obese patients who have body mass index above 40, we will not operate on until they're going through a nutrition and weight loss program. And we also very strongly have people work with our smoking cessation team because any modifiable risk factor like diabetes, we try to control prior to surgery to reduce the risk of those bad complications. Great question, though.
Thank you very much. Thanks a lot. I appreciate it. That's all. Those are my questions. Thank you.
Thank you so much, Dr. King. Our next question
Sure.
is, are there alternatives to joint replacement surgeries?
I'm sorry, what was the question?
It was, are there alternatives to joint replacement surgeries?
Yeah, there are. Yeah, we have a lot of alternatives with like medications, physical therapy, fitness programs. And we also, in cases of advanced arthritis, in people who can't have surgery, do injections into the joints, cortisone or hyaluronic acid injections, which can help relieve symptoms. In some rare cases, we use nerve blocks to block the pain signals that are coming back from the affected joint. And so that is very commonly used in people, for example, who don't want surgery or who are too, have medical problems like uncontrolled diabetes that prevent them from having surgery. Unfortunately, the problem with all those technologies and non-operative options is that we don't have a way to cure the underlying problem. And so all we're doing is treating the symptoms, but at current, we're hoping perhaps stem cell therapy in the future may provide an opportunity to cure the problem. But until we have opportunities to cure the problem, the cure always requires surgery, and the conservative treatments can be helpful, but unfortunately not curative.
Thank you for that answer. Our next question is, you talked about runners with advanced knee damage switching to other sports. Would post-knee replacement, is that recommendation the same, or would they be able to return to high-impact activities?
Yeah, that's a great question. If you Google that, you'll see people with hip and knee replacements performing high impact activities. But it's our recommendation that you do not return to high impact activities because you may shorten the life expectancy survivorship of the device and require repeat surgery sooner. And so we do have patients who do all those things, but I do not recommend it. And I think that that goes to a lot of our counseling. We do recommend frequently, we want people to be active, but we would prefer they ride a bike or swim as opposed to run, or use an elliptical machine instead of, run on the treadmill. They can hike, walk, people play tennis, people play golf. But in terms of like very high impact racquetball, running, volleyball, those type of things, although technically possible, are not advised.
Thank you. Our next question is from Olivia. Would hyperextending knees make a difference during surgery?
Yeah, it depends why. Yes. So hyperextending knees, a normal knee, like in a normal knee, like in a young woman, for example, usually has 3 degrees of hyperextension, the 5 degrees of hyperextension, and that can be completely normal. And so that is totally okay. If people have advanced arthritis and they get uncontrolled hyperextension, where the hyperextension is very advanced, that can compromise the results of the knee replacement if it's not addressed. But we have ways actually to address that, to improve the stability of the knee and improve the function after surgery. But again, a normal knee, and particularly in like a young woman with no arthritis, some hyperextension is in many cases completely normal and actually good for the knee kinematics.
Thank you. Our next question is, what effects can bad posture have on your spine? Are there any serious complications that can arise due to this?
Very good question. Yeah. So out of my subspecialization area of expertise, but yes, like we see all this information now about called text neck. Everybody's looking down at their phone like this, causing cervical problems in the neck, cervical arthritis, disc herniations, which can pinch nerves going down into your fingers, and the same thing in the lumbar spine. And so poor posture, poor core fitness, poor fitness overall can actually predispose to back problems, back pain. And we find that everybody, one of my teachers told me that ever since, so like as, people evolved, from and became upright, you think about, your, classes on evolution, has as humankind became upright, it put tremendous stress on the spine. And so everyone with age appears to get some type of degenerative change in their spine. But we find that people who have good posture, good core strength can tolerate that degenerative change with hardly any symptoms, while people who have bad posture, bad core strength sometimes can be debilitated by the spine and neck problems. Yeah, so good posture is strongly recommended and throughout your life for sure.
Thank you. Our next question is, what are some preventative measures for osteoarthritis?
Yeah, preventative measures for osteoarthritis, the biggest association with osteoarthritis is actually body mass index or body weight. And so people who are substantially overweight have a much, much, much higher risk of developing osteoarthritis, of being symptomatic from that arthritis, of being affected by that osteoarthritis. And then unfortunately, they have a much higher risk of having a complication if they have surgery to treat the arthritis. And so yeah, keeping your muscles strong is important to stabilize the joints, but probably the most impactful thing you can do is maintain ideal body weight to protect the joints.
Thank you. Our next question is, does it help to have more physical strength as an orthopedic surgeon?
Oh, that's a great question. It depends on the subspecialty. And that goes back to my little joke, my little silly slide I showed about the stereotype of the orthopedic surgeon as the dumb jock or the ex-football player. So when you're doing hip and knee replacements, there is some physical strength involved that's perhaps more than if you were doing like a carpal tunnel surgery, for example. But I don't know how much you can see of me on the, I'm like a runner, biker, little thin guy. So it's about like learning ergonomics and keeping yourself strong. You don't need to be some muscle bound, weightlifter to do orthopedics at all. There are many, very petite, men and women who do the surgery that I do. And so, yeah, that is not necessary.
Thank you for that answer. Our next question is, as an orthopedic surgeon, how would you characterize the role or importance of patient relationships? And do you typically see patients once or long-term? And does that affect your approach to patient interaction?
Yeah, that's a nice question. Yeah, so the patient relationship is really fundamental to the, to the success of the procedure. So my patients who I do surgery on, I will see them actually for a lifetime. So we'll see them, around the surgical time a lot, before surgery to prepare them, after surgery to make sure they're doing okay. But we actually follow x-rays on a biannual or every third year basis, essentially for their lifetime. And so I've been in practice now for 20 years and I still see patients every month who I operated on, 15 or 20 years ago. And so it is very nice, at least in my subspecialty, that we do develop a longitudinal relationship. Now, some of the special, hand surgery, if you do a carpal tunnel surgery on somebody, my hand surgeon partners does a carpal tunnel surgery, releases the median nerve at the, at the wrist, and the patient doesn't have numbness or tingling in their fingers anymore. They may see that patient just 2 or 3 times and not need to see them again. So it varies by subspecialty, but I particularly enjoy my subspecialty because I do develop a longitudinal relationship with the patients. Many of my patients also who have problem in one hip will later get a problem in the other hip or the knee. So once these people have osteoarthritis in their joints, it may affect more than one joints. And so I have many patients who I've fixed, 2, 3, 4 joints on the same patient. So I joke that I am like a, no insult to any family doctors on the line who are doing amazing. I joke I'm like the family doctor of orthopedics, because the patients come back to me again and again with their different orthopedic problems.
Thank you, Dr. King. I'll now pass it off to Hamza to finish our Q&A.
Thank you very much for that incredibly informative session, Dr. King. My name is Hamza, and I'm attending a joint BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine, both of them in Pennsylvania. The first question we have is, what are your thoughts on the social determinants of health when it comes to post-clinical outcomes for patients undergoing a total knee or hip arthroplasty?
Yeah, that's a great question. And that's a subject of ongoing study. I just had a meeting with our research, a group of our research team this week about that very thing. Yeah, we have found in our published study 3 years ago that we unexpectedly found that our African American patients in our population had inferior outcomes compared to our white patients, and have really embraced that. They stayed in the hospital longer, they were less likely to go home, they were more likely to develop scar tissue. And now we've subsequently found, and Manahil has helped us with this, we subsequently found that patients coming from underserved areas in Maryland, regardless of their race, appear to have higher utilization of the emergency room after surgery, longer length of stay, more likely to need to go to a nursing home. And so we've actually received a grant to study this from the Robert Gladden Foundation and the Orthopedic Research, RAF, Orthopedic Research and Education Foundation, to study how to improve those factors. It's very important to us that everybody have the best chance at the best possible outcome. And so one of the things we're doing, we have a nurse navigator, Stephanie Dolly, who's amazing, and she's actually spending time providing outreach to patients who we think might need some extra help. And we're also going to announce, I think in the next week or two, a partnership with a major company to use patient engagement app-based technology to help provide additional outreach to patients who may be from underserved areas or are in an underrepresented minority, to try and improve the outcomes in those patients. And so that's part of our research, and that's extremely important to us. And Manahil can probably comment on this too, because she's extremely intelligent and active in this area.
All right, thank you very much for that answer. The next question we have is, can you discuss a little about ACB, adductor canal block, and if you know how it improves post-clinical outcomes versus not performing the adductor canal block?
Boy, we're getting into some really technical stuff now. I like it. Yeah, so we actually just looked up our adductor canal block series. So anecdotally, our patients report less pain after the surgery. And so it appears to improve short-term pain relief. For those on the call who don't know, the adductor canal block is an ultrasound guided block of one of the terminal branches of the femoral nerve, the saphenous branch of the femoral nerve, which provides sensation over the medial and anterior aspect of the knee. And so by ultrasound guided block performed by the anesthesiologist immediately before the surgery with a long-acting anesthetic, we can block some of the pain signals that are coming back after the knee replacement. And so anecdotally, our patients have reported less pain after the surgery. When we dug into it with a study of our patients, we saw slightly less pain, but we didn't see improvement in length of stay, for example, or long-term variables. And so I think that perhaps if we looked at hundreds of thousands of patients, we would see a benefit, but it would require a very large sample size to power that study. And so I think anecdotally, people say it helps. The study shows perhaps some modest improvement in pain. I think if I had my knee replaced, I would definitely get one, which is probably the true tell-all, because I do think it helps patients with pain in the early hours after surgery.
All right, thank you very much for that answer. We have another question. Can you tell us more about the different types of anesthesia, for example, general or neuroaxial anesthesia, and how you make the decision with the anesthesiologist?
Yeah, and that's a very good question. That's an area of our study as well. The general anesthesia is usually involving inhaled agents that are passed through a ventilator, which requires airway control, meaning intubation of the patient. And then the anesthesiologist, the patient is unconscious under general anesthesia. The airway is under control of the anesthesiologist, who's giving the patient a combination of intravenous medications and inhaled agents. Like the original one was ether. So they're like basically controlling the patient's respiratory function during the surgery. The patient's unaware of what's going on. In order to obtain intubation, the patient is most frequently paralyzed with a neuromuscular paralytic agent. Now, spinal anesthesia involves placing a needle into the cerebral spinal fluid in the lumbar spine and injecting some local anesthetic. You would think about lidocaine when you go to the dentist to have dental work done. So that a similar version of that medication can be put in the spinal cord in hip and knee replacement to cause the body to go numb, basically below the level where the medication is inserted. And that's similar to, for example, when a woman would have an epidural anesthetic during childbirth to to block the pain signals coming from the uterine contractions associated with childbirth. And so both of those types of anesthetics are fine for hip and knee replacement. We have found in our research that the spinal anesthesia, I use the term pure, patients seem to do better after spinal anesthesia. And I think that's because they breathe on their own. They don't require these inhaled agents, which can sometimes cause nausea, delayed grogginess. Older people sometimes get confused when they have general anesthesia. And so we find the spinal anesthesia to be pure, for lack of a better word. The patient's numb, we give them a sedative, but we don't need to put them on a ventilator. We don't need to put a breathing tube down their trachea. We don't need to give them these very powerful anesthetic agents. And those patients who have the spinal seem like they wake up more quickly, more refreshed, and are able to walk around much quicker. And our studies have shown that they are able to go home from the hospital sooner and generally have a better experience. And so our studies support that very strongly. We've published those studies. And if I was going to have a hip or knee replacement myself, I would definitely have a spinal anesthetic. Not all patients are obviously candidates. Some people have spinal fusion surgery or spinal disease, which prevents spinal anesthesia. So in those patients, there's nothing the matter with the general, but all things being equal, we prefer the spinal.
Thank you very much for that answer. We have 2 more questions left. I'll start with the first one. What is some advice you have for students who are interested in pursuing orthopedic surgery?
Yeah, great. Well, I love orthopedic surgeon. I think orthopedic surgery is a great field, and I'm very, very happy that I chose it. And I love the work that I do and what I'm able to do. Now, when I was I loved the medical school is challenging, but I loved it. Residency is challenging. I loved it. In medical school, and even before medical school, I really took the time to explore a number of specialties. I thought I might be an obstetrician or an emergency room doctor or a pediatrician. And so, really, I think that using the opportunities to explore the different areas with shadowing. When you're in medical school, you do clinical rotations and try to experience the environment, in a real way where you're actually immersed in it, so you can really see if it's something you can see yourself doing for your whole career. Obviously, these are, really, 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 really big decisions. And then I think once you find what's perfect for you and you set your mind to it, then you just have to, you just basically go for it. You direct yourself in that, goal and, do what it takes to accomplish it.
Thank you very much. And for our final question, how do you manage your work-life balance?
Oh, it's a very good question and very challenging. And my slide about the hurdle and enjoying the ride, you do have to be very, very careful. Not, you want to get to medical school, then you want to get your residency, then you want to get your fellowship, then you want to have a good practice, and then you want to have a better practice. And so it's very important to make sure you enjoy the ride. And so I enjoy spending time with my family and taking walks, and I exercise a lot, which is a good way to decrease the stress. And then I have this amazing team that works around me now to help me, so that, every single, question and phone call doesn't have to come to me. So it is important that if you're not in a good place yourself, if you're not in some sense of balance yourself, you won't do your patients any good, right? So you have to start from a place of balance to provide that same balance and appropriate care for your patients.
Great. Thank you very much for answering all of our questions, Dr. King. Those are all the questions that we have for today.
Okay, great. Thank you very much. I enjoyed speaking to you all, and I hope you found that helpful.
Thank you very much, Dr. King. We really appreciate you taking the time to answer all of our questions and volunteer on Saturday morning to teach us. We learned a lot. It was a great learning session for all of us. I know I also learned a lot of new things. I'd love everyone to please give a warm thank you to Dr. King in the chat box for this incredibly informative session.
Yeah, and thank you, everybody, and best of luck on your journey. And I wish everybody great success, in medical school and beyond.
Thank you.
So everybody have a great weekend.
You too.
Okay, thank you very much.
Thank you.
Thank you.
Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for this session is now live. Again, you'll need a 70% or higher to pass and receive certification, and that link is being sent in the chat now. And don't forget to join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox. You can join from the link in the chat now. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session next Saturday on October 23rd at 10 a.m. Eastern Standard Time with our physician mentoring us in sports medicine, family medicine, and pain medicine. Thank you so much for everyone for attending today's session. We hope to see you in upcoming sessions as well. And this concludes this week's shadowing session.